So my name is Heather,
My name's Curry.
and this is our project on health disparities and health equity and how the universal healthcare system has decreased inequalities in healthcare and health disparities between groups in Costa Rica. Some important terminology to understand is first the CCSS, which is referring to the universal healthcare system. Another term that is important to understand is EBAIS, as you see here, which refers to the primary healthcare system teams, which are in Costa Rica. And then another term to mention is MCS, which are management commitments, which are performance agreements for government management of EBAIS teams. Okay, so the original goals and objectives of this project of the healthcare reforms were one, to extend coverage, and two, to provide more comprehensive overall care to Costa Ricans. Okay. All right, some strategies that were implemented were first, the development of EBAIS, which was a team model of multidisciplinary functions that had the goal of delivering comprehensive care to resolve acute and manage chronic diseases to Costa Ricans throughout the course of their lives. In 1995, the first EBAIS team began working. EBAIS teams provided a first point of contact for all health services, and it initially consisted of a doctor, nurse, and public health worker that were assigned to specific geographic regions. So each EBIS team is generally responsible for providing care to 1,000 families or approximately 4,000 patients. In 1996, to help manage the EBIS teams, the Costa Rican government introduced performance agreements that were known as management committees, or MC. MC set targets for priority health areas, such as including indicators of coverage, quality, efficiency, and user satisfaction. In 2000, more progress was made. EBAIS began to construct new buildings to house their services, and the majority of EBAIS were now in their own buildings rather than using other organization buildings, and they were taken much more seriously. Today, EBAIS teams include an administrator, pharmacy assistant, primary healthcare technicians that are all responsible for conducting home visits for the elderly and immobile populations, which is making it more comprehensive and not available to just people who have money. EBIS was so effective because they divided the country into 104 geographic areas and assigned each person within those areas to an integrated primary healthcare system. All of this equated to Costa Rica being able to achieve the essential functions of high quality primary health care, which include continuous, comprehensive, coordinated, and patient-centered care that services that serves as the first point of contact for health encounters. Okay, so some activities that the government did with the people of Costa Rica in order to make healthcare more accessible and comprehensive were to implement prevention programs like vaccination, growth monitoring, and family planning. As a result of high immunization rates, 91% of Costa Ricans were immunized, and improved sanitation occurred, and improved access to comprehensive health care. Deaths in Costa Rica due to communicable diseases dropped from 65 to 4.2 per 100,000 people between 1990 and 2010. Another thing that they did was implementing MC. That requirement that was implemented was that physicians had to be present at their primary care center Monday through Friday, which notably reduced physician absenteeism. So people were able to actually have access to their primary healthcare provider more frequently than they were before. And in the beginning, the first EBAIS clinics were placed into areas with the most healthcare needs, like areas with little pre-existing access to care and areas of great poverty, such as rural areas. Today, EVAIS teams conduct health surveys and contribute to civil registration and vital statistics to data collection.
During this process, there were various barriers that the government encountered that they had to overcome. First was geographical access. All of their resources originally were focused on urban areas, and rural areas lacked the infrastructure as well as the access to healthcare. And so they had to greatly focus their abilities towards those rural areas in order to decrease the disparities in those areas that existed from their previous governmental decisions. When they implemented this process, they first implemented into those rural areas like we discussed, and then worked backwards towards urban areas to minimize those disparities. The next major barrier they encountered was their economic crisis. The initial idea for the implementation of this CCSS and the EVAIS teams came from an economic crash and then a following measles outbreak. They knew the importance of change that needed to happen because they lacked the infrastructure to support their vulnerable populations through this process. And so they decided that they needed to do this universal healthcare system. Because they were also in an economic crisis, however, they had to go to the World Bank and got a loan that was to be paid back over 17 years in order to start this. There was also an increase in non-communicable diseases that they've had to deal with. Circulatory diseases has increased from 25 out of 100,000 deaths to 120 out of 100,000 deaths. And there's been a 48% increase in all types of cancers. There was initially a very weak vertical integration of the primary, secondary, and tertiary system. So they were doing a lot of tertiary care. They recognized that importance of the primary and secondary treatment, and they have focused a lot of preventative measures, which is not often seen for people in those vulnerable populations, but that primary and secondary treatment has really been able to decrease the disparities in their areas to stop a decline before it even happens. The increase in the aging population in Costa Rica has also caused some issues. It contributed a lot to the non-communicable diseases, as aging populations are more at risk for those. There's been long wait times for EVAIS teams, especially during the implementation process, and especially for specialties. This has pushed people back to emergency rooms sometimes, and they don't want that to happen because emergency rooms cost 2 times as much as using the EVAIS teams. So they've been pushing for more education, and they've been increasing the number of EVAIS teams that they've had around their country. There's been claimed that it's a cumbersome process for migrant, poor, and vulnerable populations to enroll in the universal healthcare system. This has made it easier for those who don't feel the need to focus on the vulnerable populations to skip out on pushing for those. However, as the entire system, especially with the MCs, has been able to focus on decreasing health disparities for vulnerable populations, they've been able to push through that and have been able to ease that process to help those enroll. Providers that didn't want change to this process did occur. They, to fix this, they essentially did a 10-year program where those who did not want to change were encouraged to retire. So they weren't forced out immediately, so it wasn't dramatic. However, they were forced to either change or retire. And then digital technologies. Costa Rica over the last 20 years, especially since implementation of this in the 90s, has had to increase their digital technology abilities, especially in the rural areas, in order to collect the data that they've desired to do through this entire process. When implementing these strategies and doing the activities, as well as working through their barriers, they've learned a lot of different lessons through this process. As they've expanded the entire universal healthcare system as they desired to do, to make it universal, because they wanted to decrease those health disparities, and that was such a focus of making this universal healthcare system. In 1990, the system only included wage earning workers. By 2003, 89% of the population was included in the system, and by 2016, 94% of the population is enrolled in this system. They've learned a lot about change. So both with those providers who didn't want change and for those in the government that did not want to support those vulnerable populations because they don't understand the hardships. They've had hesitancies that they've had to work through. That 10-year plan really helped with those hesitancies. Also, as time has gone on, they've had to change their focus of the what they are looking at, both acute and chronic illnesses. And that's a lot of what the MCs have helped with. They've established different parameters that they need to fall into and have been able to change those every few years to follow the focus of the needs in the healthcare system. With the MC implementation, they learned that accountability and prioritization is very important. Without something to truly hold people accountable and to show what the priorities are for the government, it was hard to both encourage physicians to even show up, let alone focus on the diseases that needed the most focus. However, with the MC implementation, there was a period where people felt like there was too much focus on community or country growth as a whole, that some individuals were overlooked that did still need help. And because of the MCs, the physicians were forced to focus on the group as a whole, so that they eventually figured out that they needed to have individual and community focuses and more broad MCs to specify what they needed to focus on. During this whole process, they've really emphasized data collection. So throughout everything, they've before even digital technology was where it needed to be, they were taking data on paper to assess the performance against their target goals and to be able to improve the quality of care, to promote improvement, and to be able to provide objective assessments of both what the disparities are in certain areas so they can focus on those, as well as assessments of what the government has been able to accomplish over time. Like I said before, with the barriers, digital technologies, they've learned a lot about what they can do to spread those technologies into rural areas and what those technologies can do to increase the ability for physicians to provide adequate care. They also learned about the multidisciplinary teams. As Heather talked about, they originally were just multidisciplinary teams, but they were very small and they've expanded. So they always include a physician, a nurse, a pharmacist, and medical clerks, as well as other personnel which follow under ATAP, so that they have community health workers and others, but they have a core system that they are aiming to follow through with those multidisciplinary teams. Looking at different data, there has been a very important data collection that focused their expenditure distribution. To decrease health disparities, they focused 30% of their expenditures on the poorest 20% of the country. This emphasis on providing equity has been proven to work, as they have decreased the potential years of life lost in those populations, as they were much more drastic in the poorest areas. They've been able to decrease the potential years of life lost in the poorest 20% by 48%. While this program has worked overall, they've decreased it 39% in the richest 20% of the country. But because of the disparity that was already in place, this greater decrease in the poorest 20% proves that there is definitely more equity between the two populations now. And this was also super important of their implementation of rural to urban area. Perinatal mortality has decreased from 12 out of 1,000 citizens in 1990 to 5.4 out of 1,000 citizens in 2016. Communicable disease mortality has drastically decreased from 65 out of 100,000 citizens in 1990 to 4.2 in 100,000 citizens in 2016. Individual rates of catastrophic health expenditures. In 1990, it was at 1.56%, where in 2016, it was at 0.31%. The under 5-year-old mortality rate per 1,000 citizens decreased from 14.4 per 1,000 citizens to 10.6 per 1,000 citizens. Spending on healthcare in 2016 compared to the world, Costa Rica has been able to have all of these decreases in all of these very important areas, but they've only had to contribute 7.6% of their gross domestic product share compared to the average of the world, which is 10%. And they are drastically improving their country as a whole, which not all countries are doing currently. So that's a very important idea, that even the universal healthcare system is costing less money. Life expectancy in Costa Rica has also dramatically increased. In 2015, it was at an average of 79.6 years. This is above both the Latin American Caribbean average and the world average. The only thing that they've really had to focus on, like I discussed before, is those wait times to try to decrease those who go to emergency rooms. It was found that 50%, so half of emergency room visits, are actually non-emergencies, where 50% of them are emergencies. They want to drastically move that so that as close to 100% as they can get, emergency room visits are truly emergencies. Some future direction and goals that this universal healthcare system and the Costa Rican government has right now is their biggest thing is research. I talked about how they love taking their data, and I have been able to show all of these different data points because they do like their research. They want to back everything that they do, and they want to back all of their goals. Another one of their big points is that they still need to add about 300 more EBAIS clinics in their country to meet their goal of one clinic per 4,000 citizens. They aren't quite there yet, but that would be a goal that they have to make that. 75 of the current EBAS clinics also don't have their full multidisciplinary teams, so they want to be able to round those out. They want to decrease and prevent the burden of non-communicable diseases across all populations. There's a worldwide increase of non-communicable diseases currently, and they've really realized that they need to work on their primary and secondary levels of healthcare to try to prevent these non-communicable diseases from happening at all, as well as their tertiary to help decrease the burden of those diseases on all populations, including vulnerable populations. They also have a goal of implementing their policy for international cooperation priorities, which was stated through 2014 to 2022. So we don't yet have the results, but they're currently working on it. And one of their main priorities is to focus on vulnerable populations and the border areas of Costa Rica to decrease their health disparities and to increase equity across the entire country.
Some suggestions that we have to improve the system is to focus on the minority and vulnerable groups, specifically people who still have very low income, and to educate the people of Costa Rica on the EBAIS teams, what they're capable of, how they work, and how these people can enroll in this system and what makes it universal.
Thank you for listening to our presentation.